obesity here in India, and we know that a large number of these people have sleep apnea. From another paper, another publication from Egypt, 63% of males who have obesity have sleep apnea and 74% of females. So there is a very, very strong correlation, and I'm sure that the numbers everywhere, and also including here in India, will increase. So let's take a look at this patient. So these are two of my patients, and first up with a class 3 is Michelle. She is 33 years old, and then on the lower row you have Betty. She is also 30. Michelle is 33 years old and Betty 30 years. So they're about the same age. Let's just a show of hands. Betty has sleep apnea. Yes, right? Who thinks she has sleep apnea? Betty. Yep. So how about Michelle? Does Michelle have sleep apnea or not? Who thinks she has sleep apnea? Okay. Yep, so that's actually the case. So this is very important because she has a class 3 malocclusion, and in situations like that, I think usually you would do a Lefort advancement. But Michelle has a very, very narrow airway. She actually came to the clinic and didn't have any problems. It was not known that she had sleep apnea. That was something that we discovered at the time. She was just referred from her orthodontist for an orthognathic procedure. And of course, if you did diagnose sleep apnea in a patient like that, the therapeutic plan, the treatment plan is completely different. And on the lower CT scan here you see Betty, which is quite obvious. But I hope what I want to make the point here is that 80% of sleep apnea in your orthognathic patients is undiagnosed, or in general undiagnosed. So I think as a surgeon community who does orthognathic surgery, we need to make sure that we recognize these patients because we have to do a different surgical plan for them. We need to anticipate sometimes when they age, I rarely do these days mandibular setbacks in patients, especially if they are older. And also in a case like this, we need to recognize that Michelle has sleep apnea and that we need to do a different plan. And we need to do the workup. So an easy way to look at your patients in your clinic to sort of screen them is just do an Epworth sleepiness scale. When you do your first intake, your nurse does your intake, they can give them, this little questionnaire, do you fall asleep when you're sitting and reading, you're watching TV, you're sitting in a public place, and then, every single one of these answers is associated with a score, and the scores are then added, and if you have a score of 11 plus minus 4, you can expect that this patient probably has moderate obstructive sleep apnea, and then if they are higher, they may even suffer from narcolepsy. Another possibility is the stop-bang questionnaire. Basically same concept, very simple, yes, no questions. As a screening tool, this is something that we have added to our clinic now because very often patients are not aware. And of course, the orthodontists who are referring are not focusing on that. The patient and the orthodontist are focusing on the bite and the aesthetics and not on other comorbidities. And these patients have very different comorbidities. So I think one of the ways you discover that people have a very small airway is, of course, 3D imaging. And usually our patients undergo 3D imaging, and that has really, as you know, created a paradigm shift in CMF surgery. And I would say that this is really also a prerequisite in a sleep surgery clinic that you assess the airway with a 3D X-ray, which is not necessary for all orthognathic cases, but for sleep cases, I think you want to have an idea how big the airway is. As you know, there are multiple companies who are doing virtual planning these days. What you see here is actually one of our very old first publications about soft tissue simulation that we published in 2001 in the Journal of Craniomaxillofacial Surgery. Now, of course, these programs are available for everybody, and we can all participate in that. So how reliable is soft tissue simulation? First of all, if you are working with a sleep apnea patient, it is very important that you scan them in a supine position, because of course, because of gravity, the soft tissue in the oropharynx changes significantly whether you have a patient in a supine or upright position. Yeah, so otherwise you will underestimate also the narrowness of the airway. But be careful, because this is just a static picture and the patient is awake, so the actual situation might actually be worse. But nevertheless, sleep apnea patients, if you're doing orthognathic bimaxillary advancement for your sleep apnea patient, try to scan them supine, because it gives you a better idea of where and how bad the obstruction is. There are multiple studies now, retrospective studies, to compare the correlation of skeletal movements and airway volume in obstructive sleep apnea. And, they give you a good idea of what the static situation is. But the static situation is not the whole picture. And also soft tissue's response in orthognathic surgery and also in sleep apnea is only partially predictable. It's especially bad in the paranasal areas and in the upper lip. So it is not completely reliable. We always have to remind ourselves that virtual surgical planning is a tool that can help us, but in the end, it's the surgeon's judgment and experience how to develop a treatment plan for a patient. And you cannot say, this is what I'm seeing in my surgical simulation, this is what's going to look like, especially in the upper lip. And we had a very nice talk also from our colleagues in the AO symposium recently, especially in vertical access. The soft tissue simulation is not reliable. You can almost not use it. And also, if you look at the review papers, there's very nice systematic review here. Soft tissue simulation still requires improvement because it's clinically 100% useful. The position of the lips is very challenging. And the problem is that it's not a dynamic picture. It's basically a snapshot, and it doesn't reflect the motor function of the facial expression and the oropharynx of the patient. So simulation of dynamic function, we are getting there, and this is actually very, very important for sleep apnea patients, because the oropharyngeal airway is a complex structure that changes with the surrounding skeletal, muscular, neurologic, and systematic factors. You need 4D imaging. Yeah, because, if you see a patient, sometimes I see patients that come into the clinic, I look at their pictures before. We have pictures of SMILE or something like that, but then when I have the patient in front of me, very often I change my impression, because when I watch the patient, how, the muscle function is in the face, I get a different impression on where, for example, for aesthetic reasons, I want to put the maxilla. And I'm sure that those of you who do a lot of orthognathic surgery have had that too. So the 2D pictures that we're taking and the 2D or 3D airway, and the same is true for the airway. It is not, the dynamic function is really very, very important. So there is a way to address the dynamic function of the airway, which is drug-induced sleep endoscopy. It's becoming more and more popular, and our ENT colleagues at Stanford now use it regularly and do it regularly and make the results available. The problem with drug-induced sleep endoscopy at this time, and I don't know whether that's ever going to be solved, is really how do you classify that? Yeah, it's really more of a visual impression. Where is the obstruction in the oropharynx? Where is the collapse? Is it a lateral collapse? Is it a circumferential collapse? Is it just the tongue base? I think where it is really very helpful is when you're doing the sleep endoscopy, if you move the lower jaw forward and you can reliably open up the airway, I think that gives you a pretty good idea whether your surgery or Bimax advancement is going to be successful. But the problem is really there's no general consensus that the results of drug-induced sleep apnea predict surgical success. But I still think it's another tool in the box if we don't know, is this a good candidate for MMA, because you really want to have, a good surgical plan. I think in those cases where you're not sure, and especially in very overweight or elderly patients, this is a very good additional diagnostic tool that you can use. And so I would suggest that this is something to integrate into the practice. Of course, the gold standard is a polysomnogram, as you all know, with the apnea-hypopnea, and the classification, I think you are all very experienced, so you know the apnea-hypopnea index and the oxygen saturation and the classification of mild, moderate, and severe sleep apnea. The most important part that I want to talk about here is that in the pediatric population, AHI or RDI is definitely considered abnormal if it's equal or greater than 1. So, and we actually treating a lot of kids with craniofacial abnormalities, and in these children we very often have sleep apnea, and we have to recognize that. And it's not only because they have sleep apnea, but also because of the intubation, the airway situation, and so on. And at Stanford we have a special team for difficult airways that we use in these kids also. So, I mean, it's pretty clear craniofacial anomalies like Pierre-Robin, Treacher-Collins, or Cousins have very difficult airways and very often do obstructive sleep apnea. Very high prevalence in Down syndrome because of the big tongue, small midface and cranium, narrow nasopharynx, and very often obesity associated with it. And of course, the problems with heart disease in this population. The presentation of sleep apnea is very different in the pediatric and adult population. Kids are usually hyperactive and adults are somnolent. And in kids, it has been proven now that sleep apnea is very much connected with academic performance. Very often if kids are very hyperactive, they look like they have attention deficit disorder or something like that. Especially if they are obese or they have small lower jaws or something like that. Always look at whether they also have sleep apnea. And then, because if you correct the sleep apnea, and you can give a whole different talk about sleep apnea in children and the treatment of sleep apnea, then also their academic performance
Very much for the invitation, Mr. Chairman, and good morning to the auditorium. I am Alejandro Martinez, have no disclaimers, and this is not working. Oh, it's ready now. Okay, I am in Mexico, and I think that some of the good, important achievements I have is I love my hobbies: family, friends, fishing, diving, cooking, tequila, wines, and cigars. And I'm in Monterrey, Mexico. It's the third largest city in my country, and that's where I work. And in my office, that's where we do the surgery. We have two general anesthesia operating rooms, and we do the procedures there. The patient stays one night in the clinic and leaves the next day home. So let's go. And I'm the president of the International Association Oral Maxillofacial Surgery, and you have your colleagues, Dr. Sanjeev Nair, my brother from another mother, that will be the next president. And I invite you to be in Vancouver for next year and to join us, be a member. So here we go. So my lecture is on face 4 matters. And why do we change these faces? Why do we work them? Why do we do orthodontic surgery on them? And I think that the final goal is orofacial functions. We breathe, we swallow, we speak, and we chew. That's what we do. When we were born, the first thing that our mouth did in the face, the first function was breathing. We have to close our lips to breathe, and we do that close to 10,000 times per day. Imagine that mandible moving. And then we swallow and speak and chewing. So this is how I see the face today. These 2 slides in my mind are the most important of my lectures. We used to do films, cephalograms, to do predictions and changing the face, changing the occlusal plane for function and aesthetics. And then we start looking the joints to be careful with them. And then we went for the airway. So we need to create an occlusal plane in harmony with fundamental components. That means the skeletal, the dentoalveolar, the teeth, the joint, the airway all together. But then we start looking on muscles, on lips, orbicularis, buccinator, lateral pharynx constrictor, because with all of them, we need to perform orofacial functions. So this is how I see the face today. We know that the face is important. Cicero described it. And our faces are unique. There's no other equal, even in billions of people. And we have just 2 eyes, 1 nose, 2 cheeks, 1 chin. And with all that, we are very unique. So the face is important. It gives us aesthetics and functions, and we need to coordinate, as I said, the bones, the teeth, the airway, the joints, the lips. But we need to include buccinators and lateral pharynx constrictors. So yes, there are many papers that tell us that orthodontic surgery creates a good social impact and self-esteem and happiness and image and works. And there are other papers that will tell us that it works to function, as Dr. Girard explaining very well how it opens the airway and gives us a better quality of life. So does the face form affect orofacial functions? Does dental arch form matters? And for sure, does dental form affect function? We need to include that. We need to restore the length of worn incisors and cusp of posterior teeth, and to restore symmetry and beauty of the lips and expressions. So we need to produce a functional, beautiful face. And we need to learn, unlearn, and relearn for that. And what I like about this George Bateson sentence is that there are patterns that it connects by looking for patterns behind patterns and processes under structures. And I want to explain it. Why do we change these skeletal forms or patterns, dental patterns, muscles and joints? Because we want at the end function, orofacial function again. Breathing 10,000 a day, swallowing 4,000 times a day, and then we smile and we speak. We need to put our lips together to speak and to chew. So this is an example of a facial form, arch form, and dental form that were incorrect. They were compensated. And in order to produce a better face, you have to take care of the teeth inclination, protrusion, leveling, aligning, because they play a role for development of the face and the airway. So in this case, we have to do the opposite way of treating orthodontically and then doing the surgery. So this is what we need to do. We need to produce a tooth form, arch form, a skeletal form. So dental form, the size will be between 10 and 13 millimeters. Dental arch form, the width is 44 millimeters approx in maxilla and 40 in mandible. And the facial form, there are many facial forms that will need aesthetics but with good function. And this is literature that you can take as an example. So what we do is we like to reconstruct incisal edges and cusps before surgery, because they will, as I said, will give us a better function and stability. And this is what we want to do. Flat teeth equals relapse, so, and cusp will maintain transversal stability. So what we do now is we take a good look on buccinators muscles, because the buccinators muscles they need to have a wide dental arch. This is like a tent. You want to keep the tent good. See that, and the arch form with the cusps, the width, it needs to hold the tent, and the tent are the muscles, because lips are attached to buccinator, to the palatal raphe, and to the pharynx. So we need to expand those arches to give good form, to give good function, to keep the tent. And this is examples of expanding the maxillas. And there are literature enough that will tell us that it is important for breathing. Even in 1796, George Gatlin dedicated this book to express facial form. And he described the major problems. And then we have this paper, 1901, Dr. Engel, seeing how were the lips and the occlusion and producing a better occlusion with a better lip form, passive seal. And in 2016, then Milanesi tell us that oral breathers provoke musculoskeletal discapacity, alter mechanical respiratory function, perpetuating respiratory changes, and upper way resistance. So we need to take care of that. And there are papers that tell us that orthodontic surgery can give us a better lip force and sealing. And if we remember the development of our mouth, this is the way it goes. The first thing that is developed in our mouth is the lower lip, and then the upper lip and nasal process and tongue. And the biological conduct start by breathing, swallowing, sucking, and there are no teeth yet. So lips are the first in the hierarchy of the orofacial function development. So this is what we're doing. And look how much the mandible moves for swallowing, for speaking. Imagine those joints going out of the fossa, because the mandible has to bring those muscles for function. And this is nice papers that tell us that we swallow 2,000 to 4,000 times a day, and we use 10 to 15 kilos of forces every time we swallow. So we need to set our goals of orthodontic surgery taking care of these measures. And this is interferences at the posterior part of the tuberosity when we are when we are speaking, not chewing, just speaking. So you need to take care of vertical dimensions. And this is by, when you're talking, all those contacts that it's happening, that affects breathing, that affects function. And this is patients, as Dr. Girard showed, she's small, she's thin, she's class 2, but she has sleep apnea. She has a desaturation to 74. So we need to bring her with a better dental form, arch form, and skeletal form, because the dental interferences produce laryngeal spasm and awakening, atypical awakenings. And there is enough literature on that. And snoring, we know the history of snoring. If you snore, you will go to RERAs, and then you will go to hypopneas. All it needs is years because of laxity and kilos. That's all that you need to get the apnea. So if we offer our patient a passive lip seal, we're going to cover our facial functions by giving them a feeling of well-being and facial beauty. This is what I call painful smiles. Typical patients that had rhinoplasty, chin osteotomies, and then they got some dental veneers. But they're painful patients. They don't know how to smile. They don't know how to breathe. They don't know how to function. So you have to work them in with your orthodontic surgery in order to produce beauty, but function at the same time. And these are functional facial aesthetics. So you need to we need to understand that we have muscles, we have lips, we have buccinators, and we have the pharyngeal constrictor muscles, because the airway is a tensegrity structure that is opened by these continuous compressive structures. The mandible, the cranium, the hyoid, the teeth, and they are connected by 4 facial strings: tooth-pterygomandibular raphe, pharyngeal raphe, and mylohyoid raphe. So these fascias needs to be tight. This is why head posture, size of the mandible and maxilla, and vertical dimensions of occlusions influence the airway, the caliber, the breathing, and the obstructive sleep apnea. So it's not only skeletal bones, it's not only teeth. So this is like a patterns that connects to other patterns, and as a dance of interacting parts. So we don't see things as they are, we see things as we are. So before you choose the orthodontic or prosthetic treatment for dental occlusion correction, evaluate the face and the airway and the lips. Like these patients, they need correction. They need huge counterclockwise, but they have to have dental reconstructions for vertical dimensions. Or this other class 3 with the sleep, with oxygen desaturations. You need to take in your treatment plan that majority, 90% of class 3 will need mandibular advancement, because you will correct the occlusal plane to change the lip position, the airway, the tongue position, and produce orofacial functions. So these are cases that has flat teeth. So what we did is we reconstruct teeth for vertical dimensions, dental cups, and then we produce an arch form, align the teeth, evaluate the airway, the joints, and produce a good aesthetic position of the upper incisor, correct the occlusal plane, and bring the mandible forward to open the airway. And this is a case with a nice counterclock and mandibular advancement. So we got into 3D, and we follow the surgery. We open the airway, the tongue position, the lip posture, and this is the result. But you need to correct dental form, arch form, skeletal form. Another class 3, my last case. So we do the same. We want to produce dental form, incisal edges, cusps, and then align the teeth, produce a nice arch, evaluate joints. This is a patient, class 3, small, tall, sport guy, with the saturations to 87%. So, take the upper incisor and the occlusal plane into aesthetic position, bring the mandible forward, and this is the mandibular advancement, 9.7. You go to your 3D, do the surgery, and change the airway, the lips, and the tongue position, the hyoid position, keep the tensegrity. And this is the patient after. Good occlusion with vertical dimensions to produce stability and tensegrity in the muscles and the orofacial functions. So last pictures this is Playa del Carmen. I woke up at 5 o'clock in the morning with a coffee and start looking at this, at the ocean and the sky, the same spot. Look how it changed just in few hours. This is how it has changed orthodontic surgery in my mind. I go for orofacial functions. That's the final goal. So the treatment will be coronoplasty, orthodontics, restorative dentistry, perio if is needed, and then orthodontic surgery. Reshape, restore, reposition things. And go like this. Change, think on everything. We are all connected. So this is again how I see the face. Thinking on all components. So muchas gracias, and as Reinicke says, not only changing faces, but also changing lives. Thank you, Mr. Chairman.
Thank you, Dr. Any questions?
Thank you.
Thank you. Now we call upon Dr. Vidya Rathan to speak about management of facial asymmetry during growth.
Very good morning to all. I have been working for last 3 decades at PGI. So this gives me advantage. If you are working at one institute, you can follow up your patient and you can come to know what is working and what is not working. I have no financial interest to disclose. So coming to the topic, management of facial asymmetry during growth. So what are the main causes when we see patients with facial asymmetry? These may be developmental or acquired. Hemifacial microsomia, and particularly acquired one, TMJ ankylosis, is the most common problem which we see in growing children, and other are developmental like condylar hyperplasia, hemimandibular elongation, mandibular hypertrophy. So these are the most common causes which you will come to see in your practices. So learning objectives of this talk are what are the treatment options available for the management and when to intervene and when not to intervene. When our patient comes, as a surgeons, we have many tools in our box, and we tend to think of surgical solutions. So, and during growth, we think that operative correction would normalize the functional matrix, thereby optimizing future growth potential. Secondary deformity and distortion would be minimized, and there will be better psychosocial development of the child. So these are the procedures we may choose, maybe functional appliance therapy in mild cases. There are conventional orthokinetic surgical procedures like sagittal split osteotomy, vertical ramus osteotomy, or inverted L osteotomy. Then distraction osteogenesis has been there for last 3 decades now, and costochondral grafting was considered gold standard for correcting facial asymmetry and free tissue transfer. So let's look at some of the cases, how these tools work in our hands. This is a young 12-year female of Brudzinski type 2 hemifacial microsomia. And we thought distraction would work in this case, and we overcorrected. This is post-distraction. It has been overcorrected and chin is deviated towards the other side. But when you follow these children for longer periods, you see relapse. It is coming back where you started. And then when she finished growth, we took up her again with standard orthognathic surgical procedures, maxillary advancement and asymmetric sagittal split osteotomy. So distraction has got some limitation because of relapse. Another case with mandibular hypoplasia, we thought distraction, and we overcorrected it a little bit, but within 18 months, patient is coming back to where we started. Again, when patient finished growth, then second phase of treatment. So let's look at the literature. What does literature says? This is Mazzani from Italy. She followed some of our patients which were treated with distraction at early age. And in almost 80% of them, there was a relapse and there was a recurrent asymmetry. So there's no evidence for long-term effectiveness of early osteodistraction in hemifacial microsomia. And this is another Cochrane review which says that there is no evidence for using distraction and results are questionable. So when you subject, there are some complications associated with this procedure. You have poor vector control, and in this case we got ankylosis after distraction. Another option is bone grafts, maybe microvascular, and this paper says in patients who had a bone graft, more than 50% experienced recurrent asymmetry. So these are challenging cases. If you can wait till the completion of growth, that is the best option, unless there are psychosocial issues. For example, in this case, we waited. This is Brudzinski type 3. You can do minor touch-ups, orthodontic procedures, extractions, removal of tags. Such procedures you can do till these patients have completed growth. We waited for him to complete the growth, and then just with single surgery, sagittal split osteotomy, genioplasty, we can achieve reasonable results. He has got some lateral deficiency that can be tackled with fat grafting. Another tool in the box is costochondral graft, which has been considered gold standard. This has been very popular to treat TMJ ankylosis cases, hemifacial microsomia cases. It is relatively easy to harvest and stabilize the ramus. But does it work? This patient was treated with costochondral graft at a young age. But when you see after many years, nothing has changed. In this 2.5-year-old girl, we did ankylosis release and costochondral grafting. But patient developed re-ankylosis, patient had severe obstructive sleep apnea, and we resorted to distraction. Early results look very good, but when you follow this patient, she is getting back where we started. Still, she has got retrognathic mandible. We resorted to second phase of distraction. Still, patient is deficient. Major surgery twice, but results still are not that much reasonable. We distracted. Coming to costochondral graft, another unilateral case which was operated with release and costochondral grafting. You have good mouth opening, but when you follow these patients for longer period, still patient is asymmetric. Still patient is complaining that his chin is deviated and he will need secondary surgeries for correction. Unfortunately, only around a third of costochondral grafts are successful in the medium term, and these either collapse or cause overgrowth. This is our systematic review. We looked at the question, do costochondral grafts have any growth potential in temporomandibular joint surgery? And our conclusion was that there is no evidence for use of costochondral graft. There are 50% chances of failure. So still you want to choose this as a gold standard for managing facial asymmetry. And that's the question we ask. And this is how I treat these patients now. This is a patient of 1.5 years with unilateral ankylosis. Just release of ankylosis, minimal gap creation, just you have to release the bony ankylosed part and put some fat there that will prevent heterotopic bone formation and prevent chances of re-ankylosis. And we followed this patient. Patient has got good mouth opening, no re-ankylosis, and as he is growing, still young teenager, still facial asymmetric, but it is growing. Another case which we operated at 2 years, treated with same technique. She's not asymmetric, normally growing. If you restore function early, then you expect normal growth. Same technique, minimal gap, and she has got functional joint. But what most of the people are doing, they create wide gaps there, and then they try to reconstruct that wide gap with costochondral graft or alloplastic TMJ replacement. So we wanted to look at our patients, whether these patients are functioning well also. So we compared a cohort of patients treated with buccal pad fat with normal controls, age-matched controls, and we found that their chewing efficiency as well as bite force was 70 to 90% as much as of normal patients. And if you do not treat early or patient reports late, then these are the consequences. So early intervention, I will recommend as soon as you see ankylosis patient, just release the ankylosis. Another is alloplastic temporomandibular joint reconstruction. Because this has been working in adult patients, and now there is trend that these patients, younger patients, are being taken for temporomandibular alloplastic joint replacement. But when we see these patients have to live very long, one must continue to consider the very long timeline of expected use of this joint with still unknown longevity beyond 20 years. It's very easy, just you give CT data to the company and anyone can shove in this piece of metal into the joint area. So this is another girl. We have waited long enough to complete her growth, and now how to correct her deformity. There are three options: whether you will do alloplastic or patient-specific implant, you can do free microvascular transfer or standard orthognathic surgery procedures. Free microvascular transplant for aesthetic results, they are very poor aesthetic results because you are transferring a expressionless tissue to the face, and you can recognize free tissue transfer from a distance. This is Brzezinski type 3. Standard orthognathic preparation, and then we plan this patient with virtual surgical planning, take models, and with mirror imaging, this is what we expect. We did maxillary advancement, sagittal split osteotomy, and took bone graft from the iliac crest, which is non-vascularized. This is what was expected, and we harvested same piece from the iliac crest, and pre-bent plate was used, and this is the result with standard conventional orthognathic procedures and standard bone grafting procedure. Comparison. So another issue is hemimandibular elongation and mandibular hyperplasia. So you have condylar shaving. Most of the procedure is done is condylar shaving to mitigate growth. But these are self-limiting pathological processes by virtue of their non-neoplastic nature. Function of TMJ, regardless of the severity of the facial asymmetry, is normal in these patients. So strong consideration should be given to refraining from any surgery until growth activity has ceased, and avoidance of open joint surgery is most patients unless it is absolutely necessary. You can periodically monitor with SPECT or PET-CT, and once there is burnout phenomena, with standard orthognathic procedures you can achieve reasonable good results, predictable results. So just to conclude, early treatment is not a definitive treatment. Functional corrections such as severe obstructive sleep apnea should be treated early. And when patient has got severe psychosocial issues, you may resort to surgical intervention. But you should be aware of relapse, that it is not a final procedure. Costochondral grafts do not work, and there is decreasing trend world over to discourage the use of costochondral grafts for TMJ reconstruction. Early restoration of function in TMJ ankylosis leads to almost normal growth. Alloplastic temporomandibular joint reconstruction in growing patients should be avoided, and surgical interventions to achieve symmetry should be delayed until completion of the growth. Thank you for patient hearing.
Thank you. Any questions from the audience?
Thank you. Thank you, doctor. We have a next presentation from Dr. Mustafa sir. He will be talking on the role of skeletal surgery on aesthetic, function and gender definition. Dr. Mustafa sir.
Can you just minimize it? Respected chairpersons, ladies and gentlemen, good morning. Well, I'm not going to show and tell who I am. Well, this is the title of my presentations, The Role of Skeletal Surgery on Function, Aesthetics, Identity and Gender Determination. As you must be well aware that nature does try to follow the principle of what is called as a golden ratio in every manifestations of creation. So this is just to illustrate the significance of golden ratio. Even Leonardo da Vinci's painting did follow that golden ratio. And very often in our orthognathic surgery, we need to take the golden ratio into consideration. So coming to the facial skeleton, it does have a great significance in terms of function like airway. It supports the globe, impacts on brain development, mastication, speech. Of course, regarding airway, much has been spoken by the previous speakers like Gerard and Dr. Martinez. So I won't elaborate much on it. As far as facial aesthetics is concerned, you need to take into consideration the proportions, symmetry, balance and form. Also take into consideration the body type, the skull type and also the facial type. It's important to analyze the vertical thirds and the transverse fifths. All these things will help you in your planning, and also understand the facial profile, which can range from being convex, straight or concave. So here is one example to illustrate the role of function in skeletal surgery. I would go one step ahead and say your skeletal surgery should also be aimed not only to enhance function but also preserve the existing function, and so that the eventual outcome should not be that your skeletal surgery could have played a role in deterioration of the function. So here is one example of a case of brachycephaly. Okay, I won't go into the features, but what does this procedure do? So normally for brachycephaly you do what is called as a frontoorbital advancement. It releases the synostosis suture and decompresses the cranial vault. It reshapes the cranial vault and helps in advancing the supraorbital bar, thereby providing improved globe protection and improved aesthetic appearance. So that's what we did. This is the frontal flap that was raised, craniotomy. Once that is done, the frontal bar is marked and the frontal bar is taken out. It's reshaped, advanced and fixed. You can see the fixation is done with the resorbable plates because it's a young 2-year-old child. And then the cranial vault is reshaped and put back into position. And you can see we have to some extent restored the cranial vault position and shape, and you can see the effects of frontoorbital advancement. So here is another example of a very rare case of TMJ ankylosis with cleft palate. The patient had undergone the lip repair earlier. So what we did is we did the palate repair and release of the joint simultaneously in order to restore the function. And there are two functions involved here. the function of jaw opening, mouth opening, the function of speech. So both were restored. And if you look at the patient from an aesthetic point of view, you would see the asymmetry is markedly reduced. Of course, we did use CC graft for this patient, and Dr. Vidyarathan has mentioned that it has no role, but there is some role, and you can see that very clearly in this patient, if you look at the outcome. You see, we had used the CC graft in this patient, and we also analyzed the airway, so the post-op AHI index is only 1. So here is another example of a patient with internal condylar resorption, and he had this bird face deformity. Also evidence of sleep apnea. So what we did is a counterclockwise rotation of the MM complex, and phase 2 we did a double sliding genioplasty. So I would not speak about how it is done, but in these kind of surgeries, the sequencing is of prime importance, especially if you are doing a counterclockwise rotation, and if the maxilla has to be downgrafted, then it is preferable to do mandible first. So that is the double sliding genioplasty with a custom-made plate, and that is the outcome. And look at the airway, there is improvement as far as the hypopharynx is concerned. And here is another example of a patient with anterior open bite who complained of two things. She said, I can't bite an apple. So she had masticatory issues. She also had lisping. So what we did is, we did a clockwise rotation of the maxillomandibular complex with genioplasty. So for clockwise rotation, it is advisable to do maxilla first, and that is the outcome of that patient. So whether you do maxilla first or mandible first, as far as your planning is concerned, the planning is dependent on what maxillary procedure that you do. The point of rotation primarily is decided by the maxilla and not the mandible. So here is another example of a patient who had previously undergone surgery for bilateral TM joint ankylosis. Her mouth opening was reasonably good, but progressively reducing, and she had undergone previous orthognathic surgery, so she wanted aesthetic improvement, also improvement in terms of function of mouth opening, and she also had sleep apnea. That's the CT scan. So phase 1, what we did is we did the TJR plus orthognathic surgery simultaneously. So step 1, we redid the gap arthroplasty to create adequate space for the TJR. Then we went ahead and did the maxillary procedure of intrusion by 6 mm and downgrafting by 2 mm. We did the fixation of the maxilla first, and we used a custom-made computer-generated maxillary bar in order to fix the maxilla in a very accurate position. And the second stage, we did the advancement genioplasty. So you can see that maxillary bar there, giving some degree of accuracy for your counterclockwise rotation. And you see the TJR in place, and the TJR will also help you to enhance the function, also improve the stability of the maxillomandibular counterclockwise rotation. So that's her. You have the mouth opening that is improved, and look at the profile. That's the pre and post X-ray, and the profile view of the patient. Now, in terms of cleft maxillary hypoplasia, you need to take into account that the surgery that you do preserves the function of speech, does not contribute in causing VPI. So AMD is one such procedure which will not affect the velopharyngeal mechanism. So this patient had borderline VPI, and we did a AMD for her. That's her, the post-op. Okay. So here is another patient of cleft maxillary hyperplasia with the borderline, with good speech, but dentally compensated. She had undergone orthodontic treatment earlier. So we didn't want it to do too much of an advancement and deteriorate the existing speech. So we did a clockwise rotation with concomitant roll, pitch, and yaw discrepancy was also addressed simultaneously. So that is the detailed treatment plan. But I'll show you this video, which will, you see the LFO1 advancement of 4 millimeter. Maxillary yaw correction, 3 millimeter to the left. Downgrafting the maxilla by 3 millimeter anteriorly. Posterior impaction by 2 millimeters. Settling BSSO, and then genioplasty. So that is the outcome of that patient. And in these kind of cases, as I mentioned earlier, preservation of function also should be taken into consideration. That is what I'm trying to illustrate. So that's her profile. Pre and post X-rays. Here is this gentleman who is aspiring to be a gym model. He has a short, square face, and this is what I'm trying to illustrate is how you need at times to match your face to the body type. So he's a tall guy. That's him. He wants to be a gym model, and you can see his 8-pack abs. So he wants his face to match his body type. Okay, that are the preoperative records of the patient. So what we did for this patient is we did an angulostectomy. We also did a BSSO advancement and downgrafting of the chin, advancement and downgrafting of the chin. So from a convex profile, we have converted this patient into a straight profile, from a short square face to a long oval kind of a face. And here is the message that I was trying to convey earlier, that you should also anticipate the future problems that could arise from patients like this. Look at the airway. So now, if you look at the post-op lateral ceph, that's enough evidence to suggest that the airway space is considerably improved, and you are trying to negate whatever future problems that this patients would have in terms of airway. And here is another example. This is a patient, she's a transgender, and she wanted facial feminization. She had undergone the bottom surgery. That's a preoperative record. So what we did is we reshaped the cranial vault, did an angulostectomy for her, did a genioplasty, and rhinoplasty. All the procedure was done in one go. And that is her. Pre and post X-rays. So coming to the conclusion, skeletal surgery has an important role not only in terms of aesthetics, not only in terms of enhancing function, but you should also take into consideration that the surgery that you do preserves the function and don't let it deteriorate. Thank you very much, ladies and gentlemen.
Thank you. Any questions from the audience, please? Thank you, Doctor. Our next presentation is from Dr. Vivek Vardhan Reddy sir, and he will be talking on surgery first orthognathic approach.
Very good morning to respected chairpersons and ladies and gentlemen. At the outset, I would like to thank the organizing committee for this opportunity. Can we have the next slide, please? Yeah. This is a topic for today's presentation, surgery first orthognathic approach. Nothing new, but I just wanted to share some of the cases done in our unit at SVH Institute of Dental Sciences, Mahbub Nagar, and also show the youngsters how to coordinate with the orthodontic colleagues when you have a case of orthognathic surgery who wish to have this surgery done at the earliest and complete the treatment as early as possible. So these are the limitations of conventional orthognathic surgery. Parents bring their children to you probably just before the wedding or just before they fly off to abroad for higher education, and you really don't know what to do with such patients because you need 1.5 years to 2.5 years time if you want to do a proper job on these patients. And also the worsening of the facial profile with the decompensation performed during the pre-surgical stage, and also psychosocial problems, and also masticatory discomfort during this pre-surgical phase of orthodontics. So the solution for all these issues is surgery first orthognathic approach. It is nothing new. Berman et al. Proposed this in 1988 and called it as surgery first and orthodontic second. Nagasaka and co-workers popularized this in 2009 by calling it as surgery first orthognathic approach. So as you all know, the classic approach gives more importance to the form than function and aesthetics towards the end of the treatment, whereas in surgery first approach, the surgeon has the advantage of looking at the aesthetics problem first and then function and form later. So just to compare these two treatments, instead of 3 phases which are under conventional treatment protocol, that is pre-surgical orthodontic surgery and then post-surgical, SFO, it has only 2 phases, almost eliminates the pre-surgical orthodontics or minimizes the period of pre-surgical orthodontics. The only issue is you have a stable post-surgical occlusion under conventional approach, but it is a semi-stable post-surgical occlusion under surgery first approach. But the biggest advantage is shorter duration of treatment. Instead of 1.5 years to 2.5 years treatment under conventional methodology, we have probably just 6 months to 9 months treatment duration under surgery first approach. So as I just mentioned, either minimizing the period of pre-surgical orthodontics or complete elimination of pre-surgical orthodontics is the key to reduce the treatment time. And these are the protocols followed in surgery first approach. We have some of the pre-surgical procedures to be performed. Let us see what is the recommendation given by various authors about the timing of bonding, what kind of stabilizing or initial archwares need to be used, and laboratory procedures, either model setup and preparation of splints or vertical treatment planning. So various authors have given different kinds of time schedules. Eric Louis, who popularized this method, who is from Chang'an Memorial Hospital, Taiwan, he recommends bonding these patients just before surgery. There is no need to start well in advance, but some authors like Ellen Ching advocated bonding time as 1 month before the surgery. All familiar procedures, there is nothing new about the surgical procedures, whether it is conventional orthognathic or surgery first approach. As I mentioned earlier, the only challenge is intermediate transient malocclusion, which can be a challenge if your orthodontic colleague is not very experienced. All right. So timing of active orthodontic phase and immediate postoperative stability are the key factors. And this intermediate transient malocclusion is again called as treatable malocclusion by Mr. Eric Liu. So you have to see these patients, like conventional patients, along with your orthodontic colleague, to see at least there are 3 interocclusal contact points, like a tripod, on the table when you do these procedures. And there shouldn't be any obvious vertical or transverse occlusal interferences. And if possible, try to have a coordinated dental midline and see that there are no buccal crossbites, which are very difficult to treat postoperatively. What about the timing of postoperative active orthodontic phase? Again, it can range from 1 week to 1 month postoperatively according to the first set of authors, and some authors recommended waiting of 4 to 6 weeks after the surgery. But we need to consider this systemic accelerated phenomena which is observed soon after the surgery, which is at its peak during the first 3 to 4 months period after surgery, and the orthodontist should utilize this advantage to move the teeth rapidly so that accelerated orthodontic tooth movement can be achieved. Well, what are the indications for SFOA? Can we treat all the cases with this protocol? I have to share one experience. I have visited Chang'an Memorial Hospital in 2007 for an international orthognathic surgery workshop. Those days they were doing only 20% of these cases under surgery first approach and remaining 80% cases under conventional approach. Along with my colleagues Ritesh and orthodontic colleagues, we visited the center again in 2013, 6 years later, and they have converted their cases, 80% of their workload on surgery first approach, only 20% of cases they were doing in the conventional way. So that was the revolutionary change they brought in their practice, so that when the patients come to you regarding change of their face, you address that problem first instead of asking them to wait for 9 months to 1.5 years with pre-surgical orthodontics and change in the facial profile, which may not be liked by majority of these cases. Well, coming to the indications, well aligned to mildly crowded anterior teeth, flat to mild curve of SPE, and either normal or mildly proclined or retroclined incisors, minimal transverse discrepancies, and the patients who do not require too much of decompensation. So these are the standard indications for surgery first orthognathic approach. I would say that you see these patients with your orthodontic colleagues, and if they are confident of treating the transient malocclusion which results from surgery, that case can be handled by surgery first approach. So your orthodontic colleagues' confidence in dealing with this post-surgical transient malocclusion is the key. I would like to show some of the cases done in our college. Young girl with the typical hypoplastic mandible, Mandibular advancement by 7 millimeters and gonial contouring. That's the post-operative appearance of the patient. You can see here 3 stages: pre-treatment, immediate post-surgery, and after the debonding. So you could achieve these results with the rapid accelerated phenomenon, and whole treatment time was just 9 months. That's how the patient looked before surgery and after surgery. Another patient with mandibular retrognathism, an advancement of the mandible by about 7 millimeters. You can see we have managed even with an arch bar here. We didn't even bond the patient prior to surgery, and can see the excellent post-operative occlusion. Another person who required orthognathic procedure for his mandibular deficiency. That's a post-treatment. You can see here considerable amount of transient malocclusion soon after the surgery, but settled very well with post-surgical orthodontics. Mandibular prognathism, treated with mandibular setback and also advancement genoplasty. You can see all the 3 phases: pre-surgical, immediate post-surgical, and post-treatment. Even the Bimax cases can be handled very well. Just an example for the Bimax case: maxillary hypoplasia and mandibular prognathism. That's a post-op result. And you can see all the 3 phases: prior to the treatment, immediate post-surgical phase, and post-debonding. So what are the advantages of SFOA? The biggest advantage is immediate change in the facial profile. Patient has come to you for that reason, and you're addressing the problem immediately. You're not asking the patient to wait for another considerable period before we operate on them. Obviously, there will be improved patient compliance and cooperation. And as I said in the beginning, either no treatment at all or very minimal pre-surgical orthodontic treatment, and the synergistic effect of orthodontic forces and natural adaptation of teeth after surgery due to rapid accelerated phenomena. Surgical error or lapse, if at all, happens, that can be addressed with skeletal anchorage systems, and the biggest advantage is reduction in the total treatment time. Of course, there are disadvantages. Final occlusion. The planning is most challenging and time consuming, and your orthodontist should be experienced enough and confident enough to say that, yes, this is a treatable malocclusion, which is the result of surgery, and I'm confident of doing well for this patient. Sometimes we may have to do little additional surgical movement to compensate for the post-operative orthodontic movement, as you have seen in some of our cases. Extraction cases are little difficult to plan in surgery first approach, and bone healing process is progressed under an unstable occlusal state. In the conventional way, you have the stable occlusion, but here the healing has to happen in the unstable occlusion, so you need to have proper fixation in these cases. And experienced orthodontist and OMF surgeons should know their limitations and possibilities rather than attempting every case. If a patient requires decompensation, don't try to take up that case as a surgery first approach. You explain to the patient and wait for pre-surgical orthodontics to get completed. Of course, cases with severe malalignment or exaggerated curve of P are definitely contraindications for this approach. More so, severe vertical and transverse discrepancies, and where there is a severe arch incoordination. So these are the limitations of this approach. As I said a couple of times, the occlusion cannot be used as a guide to determine the skeletal position. It is the aesthetics which determines, and the unstable occlusion has to be managed well. In conclusion, I would like to say that face first approach should be emphasized to create the best preferred facial appearance for each patient, and facial aesthetics should not be compromised or compensated by dental occlusion. Of course, the orthodontist should have the ability to manage any malocclusion which is the resultant of surgery, but without sacrificing the facial beauty. I just want to thank my mentors, Professor Bhaskar Rao Garu and Dr. Paul Salins, under whom I could learn the initial surgical career of mine happened in this great institution, SDM College of Dental Sciences. If you have not recognized the last person, that was me in 1994. All right. Of course, I have learned great deal under Mr. Adrian Sugar, who just retired a few years back from Morriston Hospital, Swansea, who allowed me to do my first sagittal split osteotomy as a senior house officer in 1997. And our team in SVS Institute of Dental Sciences, we thank our faculty and PGs of orthodontics and all our staff in the department, present and former staff. Thank you all for your patient hearing, and thanks for this opportunity. Thank you.
Thank you, sir, for throwing light into new concepts in the orthodontic surgery.
Thank you.
I have a small question.
Yeah, please.
The patient is not in a hurry. Still we will go for surgery first, or we'll wait for the conventional treatment and then plan?
Personally, I always, after interacting with the patient, I would like to see the patient along with the orthodontic colleague who is going to handle this case. I would give both the options to the patient. But personally, if it is a BIMAX case with a lot of compensation and all, I still prefer going the conventional way, because you know what you're doing, and the orthodontist has very little work post-operatively to settle the occlusion. But if they are in hurry, if they can't wait, and if they are little concerned about the change in the facial profile due to the pre-surgical orthodontics, because our orthodontists are very experienced, we do not hesitate to take up such cases with the surgery first approach, and we are doing it on regular basis.
Thank you, sir. Any questions?
Thank you.
Now we call upon Dr. Thomas Zakaria for his presentation on relapse in orthodontics.
Good morning, respected chairpersons and members of the audience. Next slide, please. Next. I have no conflict of interest. Next slide, please. The topic of my presentation is relapse in orthodontic surgery. I'm a professor in Department of OMFS, Meenakshi Ammal Dental College and Hospital, Chennai. See, stability is defined as the maintenance of the skeletal and dental structures in the intended position over time. Failure to achieve stability is called relapse. So when and where does relapse occur? See, short-term relapse occurs in the immediate post-operative period within days to months. Causes being improper surgical planning, model surgery errors, intraoperative surgical errors like excessive surgical movement, osteotomy site errors like slippage or intersegmental movement, and problems in the condylar or proximal segment that include improper seating of the condyle leading to condylar distraction, rotation of the proximal or ramal segment. Long-term relapse occurs over years from unbalanced forces in the stomatognathing system, causes being growth, physiological adaptation, resorptive changes of the condyle. I'll just take these important factors one by one, few of these. Preoperative errors leading to early relapse. You always remember that surgical planning that disregard the limitations of both the direction and magnitude of skeletal movement increases the risk of early relapse. When anteroposterior movement of any one jaw exceeds 10 millimeters, the surgeon should always consider an alternative technique like distraction, osteogenesis, or concomitant bone grafting. Treatment planning errors like surgical movements that result in excessive counterclockwise rotation of the facial skeleton should be avoided as it contributes to early relapse. For that, you need to understand the surgical anatomy of the muscles of mastication that are associated with the proximal and the distal segment. You have the insertion of the masseter and on the ramus and of course on the temporalis on the coronoid. And then on the medial aspect, you have the insertion of the medial pterygoid. And that shows the attachment insertion of medial pterygoid not only on the distal segment but also on the proximal segment. And you can see the relation of the osteotomy line of the BSSO cut in relation to the medial pterygoid attachment. So when you have a counterclockwise rotation of the distal segment, there's going to be a tension and a stretching of the pterygomastocytic sling that's going to cause a tension and then relapse. So these kind of procedures are a little unstable. Improper surgical records and model surgery planning. I don't want to delve too much into this, but any inaccuracies with centric bite recording and inaccurate Facebook transfer will cause errors later. Early relapse due to intraoperative errors. Intraoperative errors, especially the failure to seat the patient's condyle in the glenoid fossa during surgery, whether one jaw or two jaw surgery, will cause problems. This is a classic example where you have LIFO-1 osteotomy. There is some interference in the posterior segment here, in the posterior aspect. And when you try to fix the jaws, this will cause you to pull the mandible, the condyles forward, distracted, and in IMF, and you'll fix it forcibly. And after GA, when the condyles relax back into the normal position in the glenoid fossa, there's going to be a posterior gagging of the occlusion and cause an anterior open bite. As you can see here, the condyles are being distracted and forcibly fixed in IMF. And when you release the IMF, the condyles relax, and there's going to be anterior open bite. This case is an example where we had an anterior open bite immediately after a LIFO-1 osteotomy. We had to, you can see the posterior gagging of the occlusion, premature contact with the molars, and we had to take the patient back into theater and remove any posterior bony interferences and then get a stable occlusion. In the previous picture, you can see the anterior open bite here. That's resolved here in the second picture. This is the correct technique of seating the condyles in a LIFO-1 osteotomy. You should have posterior and inferior forces on the chin, movement on the chin, as well as superior and upward pressure on the ramus. This is the correct technique of seating the condyle in a LIFO osteotomy. This is another patient with who required a SAG with a large mandibular plane angle and quite a bit of setback, developed an anterior open bite immediately after surgery. This was the OPG taken. You can see the anterior open bite. This is probably because of error in the pitching of the distal segment, as well as some intersegmental movements and a problem with the fixation of the fixation. This is the post-op picture. We had to again reosteum. We had to take the patient back up and refix the mandible. You can see the vertical bony defect here. That I will talk about that later. That is very important. The vertical bony. It's called the VBS, the vertical bony segment. Other factors that affect long-term stability, especially remember that post-operatively the patient's tongue position is relative to the anterior teeth, duplicates the exact pre-surgical contact with the palate and the teeth post-operatively. So that means that when any surgical techniques that decrease the size of the oral cavity, such as inferior positioning of the maxilla or mandibular setback, that will reduce the encroach on the tongue space, and that will cause relapse later. However, and over time, the tongue does adapt, reposition inferiorly, and takes the hyoid bone along with it and adapts to the new oral cavity, and it stabilizes over time. The other important thing is to mention in causing relapse is a clockwise rotation of the mandibular proximal segment. You see, again, you have to understand the attachments of the masseter and the temporalis on the proximal segment. Whenever you do a setback, you get what's known as a vertical bony step here. Now, the normal tendency of a surgeon is to try to, as we all like to align fractures in perfect reduction, we will try to align this lower border. Trying to align the lower border will actually cause a clockwise rotation of the proximal segment, stretching the pterygomastocytic sling, and over time, that tension will cause a counterclockwise rotation and cause relapse. That previous OPG I showed you demonstrated the same problem. This is called a vertical bony step. It should be maintained in setbacks. The more the gonial angle and the mandibular plane angle, the more is going to be the VBS, and lesser the gonial angle and shallower mandibular plane angles, the lesser is going to be the VBS. Also, more the advancement, more is going to be the vertical bony step. So you have to maintain that. Don't try to align this. You will cause stretching of the pterygomacetic sling and a counterclockwise rotation of the proximal segment. This patient required about 11 millimeters of setback. You can see the lower border has been aligned, and over time you can see the angulation of the proximal segment. It has rotated counterclockwise, causing relapse. Again, a common error. This is a systematic review of mandibular setback published by Joss et al. You can see mandibular setback inherently is an unstable procedure. You can see high relapse rates in short term and long term at point B and Pagonian. In this systematic review, the authors concluded that the etiology of relapse after setback is improper seeding of condyles, amount of setback, positional changes of the tongue, rotation of the proximal segment, all of which I just explained. Another conclusion by Boslap et al. Says that a steep mandibular plane and posterior to anterior facial height of 6:10 is another cause for relapse. That's again because of a steeper the mandibular plane, more is the vertical bony step. And of course, if the posterior to anterior facial ratio 6:10, what's known as a Jarabak ratio, again you will have a steeper mandibular plane and more chance of relapse. That increases the vertical bony step. The same authors did a systematic review on mandibular advancement, and you can see much lesser relapse rates in short term and long term in advancement. It's a more stable procedure, mandibular advancement. Etiology for mandibular advancement, according to these authors, is again improper seeding of the condyles leading to condylar resorption, amount of advancement, the soft tissue and muscles, mandibular plane angle. Remember, in mandibular advancement, there's a stretching of the soft tissues, and this tension causes the condyle to be retruded forcibly into the fossa. And if this condylar loading exceeds the adaptive capacity, there's going to be a resorption, usually at the anterosuperior surface of the condyle, because that is going to that's going to be located more superiorly when the condyle gets auto-rotated counterclockwise. And remember, that surface of the condyle not originally loaded is less dense in a class 2 malocclusion patient. So this is the proper seating technique for condylar positioning. You should apply a posterior force at the angle and at the same time posterior upward force at the angle and a posterior force at the anterior osteotomy site. It's called a bivector positioning. Again here, a posterior force at the angle and pushing it backwards. Passively, do not forcefully push the condyles into the fossa, especially in advancements. And this is the proper seating technique. It's again, the resultant vector is anterosuperior. Sometimes this suboptimal intraoperative control of proximal segment can also cause torquing. Torquing is basically when you advance the mandible, the natural flare of the proximal segment will cause a gap at the anterior osteotomy site. If you try to close this gap, do not try to close this gap. If you try to close this gap, this condyles will knock out laterally, torque laterally, and there will be resorption here. That may also cause TMJ problems and resorptions in the long term. Of course, you can always use condylar positioning devices. So the same authors, they have basically listed out the factors for influence from strongest to weakest. I don't want to repeat all these, I've just explained these. In Bimax surgery, what is the relation of the vertical bony step? Whenever you do a maxillary down fracture, this vertical bony step will increase here. Any impactions, this vertical bony step will decrease. So that's why these down fracture techniques are more unstable. Again, if you impact the posterior aspect of the maxilla, this again, the vertical bony step will decrease. This is the triangle proposed by Reineke in his thesis on maxillomandibular advancement, the triangle formed by ANS, PNS, and the Pogonian of the rotation of the maxillomandibular complex. You can rotate the entire maxillomandibular complex at the ANS in a clockwise direction here or in an anti-clockwise direction in that. Again, this rotation can be hinged at the buttress, and you can do the same rotations clockwise, anti-clockwise, or this rotation can be hinged at the PNS, depending upon the type of movements and the magnitude of movements you want. Showing you a few cases. This patient, a severe class 3 skeletal deformity, retrognathic mandible and a retrognathic maxilla, prognathic mandible, high mandibular plane angle 38 degrees. We did an advancement of 5 millimeters, a setback of 11 millimeters. You can see the vertical bony step in the lower border is maintained. And this, over time, this had very stable results. Biomax surgery is always more stable. Again, another class 3 skeletal deformity, a retrognathic maxilla and a prognathic mandible, high mandibular plane angle of 28 degrees. We did a LIFO1 advancement of 9 millimeters, basis of setback of 7, and a 4 millimeter posterior maxillary impaction. And that's why there is no vertical bony step. I explained to you what's the relation of the LIFO osteotomy and the vertical bony step. And again, stable results after 9 months to 1 year. This is a class 3 skeletal deformity with a low mandibular plane angle of 18 degrees. LIFO1 advancement of 3 millimeters, a setback, mandibular setback of 7 millimeters, minimal vertical bony step at the lower border because of the low mandibular plane angle. This is a bimaxillary protrusion case, a skeletal class 2 deformity with high mandibular plane angle. We did a counterclockwise rotation of the maxillomandibular complex with 1 millimeter of advancement of the mandible with a LIFO1 superior impaction of the maxilla, 10 millimeter anterior and 7 millimeters posterior. And very stable results because of the impact, maxillary impaction is always very stable. This is, of course, if you'll all be familiar with this, the hierarchy of stability as proposed by Profit. More stable procedures, maxilla up, mandible forward. I've already explained to you why that happens. Maxilla forward also. Maxilla up, mandible forward, and maxilla forward and mandible back. These are slightly less predictable, but the most unstable procedures being mandible back, maxilla down. I've already explained to you why that happens. So concluding, relapse is not just, you can't just point a finger at one particular cause. It is a combination of many different factors depending upon the type of movement, magnitude of a movement, and which jaw is being operated. To summarize all these points that I've already explained to you, these are the factors causing relapse: mandibular plane angle, clockwise or counterclockwise movement of the proximal segment with or without LIFO1 osteotomy, the magnitude of movement of maxilla mandible, type of movements of the maxilla or mandible, the role of alignment of the lower border of mandible to the proximal segment and the elimination of the VBS, role of pterygomastocytic sling, clockwise rotation of or counterclockwise rotation of the maxillomandibular complex, tongue encroachment, condylar seating, condylar remodeling, cephalometric facial types, type of fixation, and whether it's a single jaw or a two jaw surgery. Thank you very much.
Yeah, thank you for your lecture. I just differ a little bit with you that counterclockwise is unstable. The problem is that the literature you're showing and the draws you show is the classical sagittal osteotomy, which is long. And you are right. The lingual bone in the distal segment or the tooth-bearing segment will invade the pterygoid and stylomandibular ligament spaces, and that will produce relapse. But if you read if you use short split, as Epker described, and as Johan Reinicke also described in his paper in 2005 in the British Journal of Oral Maxillofacial Surgery, Volume 4, 2007, he shows that in this comparative study with clockwise or counterclockwise, that both are very, very stable. And if you do this study that the Barcelona group did with Dr. Haas, they also, in this systematic review they did, they classified counterclockwise as a highly stable procedure. And if you go and read the study by Bill Arnett and Lorenzo Trevisol, Antonio D'Agostino this year, it's in the Angle of Orthodontics, Part 1 and Part 2 in 2022, Volume 92. They give you the whole protocol on how to combine stable counterclockwise and open bites. And yesterday I showed a study we did on 27 patients where the average counterclockwise mandibular advancement and pogonium was 20 millimeters. And they were highly stable with a relapse less than 1.5 millimeters. So what I suggest is go for short splits. So the lingual bone of the tooth-bearing segment will not invade the muscle and the stylomandibular ligament. Use passive fixation, for sure double plates, as your paper from Josh said it, because it has a lot less relapse than bicortical. And for sure, good condylar position with bivector technique, as you also described. Thank you.
Thank you very much. Like I was saying, if you follow the principles employed, you can minimize relapse even in supposedly unfavorable, unstable procedures like a counterclockwise, which is traditionally believed as unstable. But like, as you just correctly pointed out, following these principles and following all the principles of doing a proper treatment planning, employing a Bimax procedure, stable fixation, correct osteotomy, I think we can minimize the relapse rates. Thank you very much.
Thank you. We have our next presentation from Dr. Lata P. Rao, and she'll be talking about BSSO in action. Oh, video.
Yeah, good morning all. At the outset, let me thank the organizers for inviting me to do this lecture. I said, I am Lata. I come from the southern part of India, Cochin, Kerala. The desire to correct facial deformities has been an old one, and we can see reports as old as 1850s. Most of the procedures were done on mandible via extraoral approach. It's almost a century later when Obwegesser came with his first report of sagittal split osteotomy. And this is a stable result. Literature shows the various modifications and the commonly used ones. It can be very easily used to advance the mandible, as we have already seen with previous speakers. Push the mandible back in case of mandibular excess. Correct the roll and yaw deformities in correction of the facial asymmetries. And then in correction of pitch deformities will have a greater bearing on the function. It opens up the airway. The counterclockwise rotation of the maxillomandibular complex opens up the airway, as you can see in the schematic diagram. So the advantages of bilateral sagittal split osteotomy is it's a hugely versatile procedure, and it has a good bony overlap. So to carry out the procedure precisely, like in any other procedure, the success lies in the proper planning. You prepare well. See the patient in a combined clinic with your orthodontist. Observe the patient from all angles. See his face, occlusion, obtain records as required, and maintain those records at least till the treatment is done. Then clinical evaluation is supported by cephalometric values. When both are in conflict, believe your clinical judgment. Then pre-surgical orthodontics in conventional method, you have to remember to warn the patient about the possibility of worsening of the deformity. Pre-surgical orthodontics is done, your orthodontist and yourself have checked and you're happy, obtain the records, and either conventional planning or virtual surgical planning, you get splints, cutting guides and plates. And now coming to the video of the procedure. After infiltration, you place the incision, it is along the external oblique ridge. You palpate as many times as you want. Locate the external oblique ridge, place the incision. Hemostasis is very important. You can see I keep on checking for the external oblique ridge. And as you reach and go up the external oblique ridge, it is the temporalis muscle you are splitting. Be aware of the pedicle thickness, which is important for subperiosteal plexus of vasculature for the mandible. You put a ramus retractor to retract the tissues, and you reflect the tissues medial to the ramus. Sorry. And I'm using a clip from another patient. You can see the reflection on the medial part of the ramus, into which a posterior border protector, channel retractor in this case, is being placed. You can see the access to the ramus. You mark the cut. It has a medial, oblique, and a vertical part. Here I put sutures through the lingual mucoperiosteum and tie it to the arch wire so that they are off from the surgical field. You start cutting. Your assistant is very important here. She needs to give you good suction and retraction. And when you come to the anterior border for the vertical cut, it is better to be done in a closed mouth position. And you place a protector on the lower border and complete the cut of the vertical cut in the lower border. The causes for bad split are uncontrolled forces and uncontrolled use of chisels. You gently walk a chisel along the osteotomy line to know whether the cortical cuts are complete. It's not a very bang kind of force, it's a gentle force. After you confirm that the cortical cuts are complete, you can start using your Smith spreader, gentle digital pressures again. You check for the springiness of the segment. And you can see if some cancellous bone is getting stuck somewhere, you can gently tap the attachment off. And the nerve may come onto the proximal segment. You have to gently tease the nerve out and position it back onto the distal side. And this is how the crack propagates on the lingual side. And you can see in a conventional cut, the lower J has completely come onto the proximal side. The same procedure repeated on the opposite side. You can see the retraction with the ramus retractor. Placement of a posterior border protector on the lingual side. You mark your cuts. Again, pull the tissues away. Here I'm using a postage stamp technique, and the holes can be connected. It gives better control. The lower border is being cut. And the cut complete, and you split the mandible. After the split is complete, you check whether the nerve is in the correct place, tease it out, put your splint, and put the mandible into IMF. And here comes the importance of if you are planning a genioplasty with the BSSO, it is better to mark your genioplasty cut before you fix the BSSO. And the proximal segment will have to go passively into it, and if there is some resistance, you can expect some disturbances from the distal segment pushing onto the proximal segment. Release the IMF, protect the nerve, and then trim the disturbance as where it is happening, wherever it is happening, you can trim. You can see the nerve is protected, and the disturbance is being trimmed. Splint is kept back. And this is a case of yaw correction, asymmetry correction with 5 mm of setback. You mark the 5 mm, cut that portion from the proximal segment, and you can see how passively the proximal segment sits back. And Dr. Thomas has already described how important it is for condylar repositioning. After you place a posterior and superior force, you can mark with pencil 2 or 3 lines. So during the procedure, you can always make sure that the lines are coinciding. The anterior screws are transorally placed, and the posterior ones, you can see the lines coinciding well. And the posterior screws are being placed via transbuccal approach. The puncture mark, trocar going in. The cheek retractor. And you can see the fixation. The same thing is repeated on the opposite side. The lines are marked and the fixation is done. I may take a minute extra. And the splint removed and occlusion checked. And the closure. So I'm always wary about few points while I plan for a surgery. Especially in borderline cases, I need to make sure where the deformity lies exactly, whether it is maxilla, mandible, or both. Like in this case, a young chap with a little bit of a facial asymmetry and a negative overjet by 1 millimeter. He was very particular that he should he should have a straight profile. So you plan, replan with either with conventional or virtual surgical plan till you get it right for the patient. So decide where it is wrong. And you have to keep in mind of the possibility of overclosure of mandible in case of total hypoplastic maxilla, as in this girl's case. Then, like has already been discussed, pay attention to airway. Literature shows that more the setback, more the problem with airway reduction. And setback more than 5 millimeter can tip a borderline OSA into a frank OSA. So be careful in obese short neck person who has a lot of submental fat. When you are in doubt, always investigate for sleep apnea. You have to know whether it's going to be a low angle case or a high angle case where the mandible can be thin and narrow and can go into a bad split. Third molar, again an issue of contention. There are cases for removal of the third molar during the surgery or before. But I always prefer to do it 6 months before. That gives me peace of mind while I do BSSO. This has already been seen, condylar sag and fixation, the importance of fixation and stability as relapse has already been discussed. So thank you.
Any questions from the audience?
Thank you, Lata, for nice. No, here.
Oh,
Just one observation. Why did you prefer bicortical fixation with the transbuccal trocar system when we can fix these osteotomies with simple monocortical
yeah, it can be done, sir, but for usually for Bimax procedures, we put bicortical screws for the mandible, that too on the lower border.
What if we have to go back and remove sometimes in these people? Don't you think it will be tough job to do
Removal
this under
is going
local
to be a
anesthesia.
tough- Yes, I do agree that, yes. Yeah, you have to
Just-
go through that transbuccal again to remove the screws.
Yeah,
yes.
just wanted clarity. Thank you for nice presentation.
Ma'am, very good presentation, ma'am. Ma'am, you have mentioned a posterior border retractor in your presentation.
Yeah.
Is it the same as channel retractor or it
It's
is
a channel
different?
retractor. Any instrument which has a cup which will go and hook beyond the posterior border of the ramus is fine.
Oh.
It can be a normal channel retractor.
Thank you.
Yeah.
Any other questions? Thank you, Dr.
Yeah, thank you.
With this, this session ends here.
Yes, sir. Thank you very much. But before that, I would request our chairperson, Dr. Jagdish Chandra and Dr. Nand Gopal Ura, sir, to please present memento to our speakers for this session. Dr. Sabine Giroud, is she here? No. Dr. Alejandro Martinez, I request you. And can we have a round of applause, ladies and gentlemen? Dr. Alejandro Martinez on the importance of orofacial functions and form in orthognathic surgery. We had a great session with him. The President IAOMS. Professor Dr. Vidya Ratan, sir, on the management of facial asymmetry during growth. I want you to be here. We have a debate coming up in orthognathic. Dr. Mustafa Khadir, sir, the role of skeletal surgery on aesthetic function and gender definition. Easy. Dr. Vivek Vardhan Reddy, sir, surgery first orthognathic approach. A round of applause, ladies and gentlemen. I think we have had a good time with so big names in the field of orthognathic. The next speaker, Dr. Thomas Zakaria, relapse in orthognathic surgery. And Dr. Lata P. Rao, ma'am, BASSO in action for a wonderful video presentation, ma'am. I request Dr. Vilas Nevaskar, sir, and Dr. Shajit Thomas to please present a memento to our chairperson for the session, Dr. Jagdish Chandra and Dr. Nandagopal Ura. And now, this was just the beginning. Now we'll move on to the next session, which is the debate, splints in orthognathic surgery, to do or not to do. To chair this session, I call upon Dr. Varghese Mani sir and Dr. Philip Matthew sir to please grace their chair on the dais as we proceed for the debate.
Good morning. We have got a debate on splints in orthognathic surgery, to do or not to do. And the moderator is Dr. Ritesh Rajan. Please, Ritesh. One more, the debaters are Dr. Benny Joseph, Dr. Arun Kumar, Dr. Srijan Mukherjee, and Dr. Dinesh Kumar Verma. Over to Ritesh.
Thank you, sir. At the outset, I would like to thank the organizers for having us here. Thank you so much for your hospitality. And I'd also like to thank for having such eminent faculty as my debaters and such eminent surgeons and doyen of orthognathic surgery himself in India. Namaskaram, sir. So, I would like to start off by just giving a little bit background before I hand over the field to the debaters. Could we have it? Number one, please. First presentation, please. Yeah. Number one. So, today we will not be discussing any procedures per se. All has been said about so much of discussion regarding various procedures after it. So we are going to just discuss a very important and critical part which is used as an aid in our orthognathic surgical procedures. We take it for granted most of the time, that splints. So we thought we'll just have a little bit discussion regarding these splints. Could we have that presentation back online, please? So as we know that the first description of a splint in orthognathic surgery was by Wassman. And like any other field, concepts in orthognathic surgery are constantly evolving. So what we probably learned when we were young residents is not what probably we are exactly practicing today. So there is constant evolution in our treatment, and we are trying to fine-tune our outcomes in patients. So though a very detailed attention to our technique for a good outcome is mandatory, but equally important is your pre-surgical planning. So how you have planned for this patient and how you are going to achieve the best functional and aesthetic outcomes for your patient is very important. And today we have evolved from paper planning to a paperless planning. So you can say that computer-aided surgical simulation, computer-aided design is now one of the most value-added addition to orthognathic surgery since the evolution of internal fixation. So exactly why are we having this debate? Isn't it a given? All of us use splints, so what's the debate about? So whether we are doing a regular phase bore transfer, anatomic articulator, transferring this to the articulator and doing a model surgery, or whether we are employing technology, doing computer-aided stimulation and designing and getting 3D printed splints, or we have moved on to the next level where we are going on to patient-specific implants. So just to give you a background as to how the direction of our debate is going to be, now we know that it is standard of care to manage any skeletal and dentofacial deformity. Orthognathic surgery remains standard of care and has been for several decades now. Even though we know that the evolution, as Dr. Lata pointed out previously, was in the beginning with more of mandibular procedures, as mandibular procedures were quite common in the beginning. And as the maxilla started being addressed for getting better outcomes in the function and aesthetics, the entire ball game changed. It was completely a new thing for the surgeons, because now you had to orient the maxilla to a cranial base, and the maxilla was floating in your hands, and you had to make sure that you are able to get good outcomes. You had to correct the pitch, the roll, and the yaw, and you have to make sure that you are putting the maxilla back in the best position possible to achieve your outcome. Then we had further evolution. We had bi-jaw surgeries, segmentalization of the maxilla. Now when you're getting segmentalization into the picture, it's not just the maxilla as a complete unit. You have multiple segments involved, you have the lower jaw involved. So it was very, very critical that you were able to get all these pieces together and get it in the correct possible relationship to the cranial base. So we have Obvigazer to thank us, like we thank up for this kind of evolution in these complex procedures. So what have we been doing? Which was quite common in past. We have been doing phasebow transfers, orienting the maxilla to the cranial base, transferring this relationship of the maxilla to the cranial base to an anatomic articulator. Then we would do the model surgery, and we would be fabricating, as we all know, that in that cold cure acrylic resins, which we used to do in the past. But now today, we have technology to help us with that. So all that plaster work is gone. So we do CAD/CAM. We have the ability now to completely import the data from your computer tomography scans into your software and move the jaws in whichever direction you want to achieve the best possible outcome. So there has been a sort of a seamless transfer from your physical model surgery to a computer aided model surgery. So still, even with your computer aided design and computer aided manufacturing, with your 3D printed splints in your hand, we are still using splints. The only rider here is that even when you use your splints, you are wiring it in the jaw, and then you need a stable condyle fossa relationship. So unless you have a stable condyle fossa relationship, when you are pushing the jaws together against the cranial base, there is still room for error. You can still have some error if your condyle is not properly seated in the fossa, and your fixation can produce some errors. So there is still scope for improvement. So still we are relying on technology now. So what is the next level? Right now we are available with, we have surgical guides or cutting guides. So it's no more, marking arbitrarily on the maxilla your lines, on the mandible your lines. You have cutting guides to help you with that. So you place your osteotomy cuts according to your cutting guides. You have the ability to use intraoperative navigation to see where your maxilla is and reorient the maxilla back to the cranial base. And now you have patient-specific implants. So already on your software, you have decided where you want to take your maxilla and where you're going to fix it. So once you have used your computer surgery and you need to transfer that results, and this patient-specific implants will help you in doing that. So with the evolution of patient-specific implants, especially 3D printed titanium plates, we are having significantly good results, which are going to be probably in the future going to be the norm. So the PSIs are now the way forward, and probably it has to gain popularity. So I'm going to start off the debate. I would like to start by calling Dr. Srijan Mukherjee first. He is going to start the proceedings. Could I have presentation number 2, please? Number 2, please. I'd like to call Dr. Srijan to take over the proceedings. Thank you.
Hello. Respected chairpersons, dear friends, I will go straight into the topic, and when I was asked to talk about this, whether we need the splint or not, I felt something like this. We all know that sun rises in the east, but it's a very difficult task to somehow explain that. So I chose to start by some basic examples in which we used that good old splint. So that's a LaFourth 3 Kaufner modification advancement and mandibular procedure. Similar, but used a bit of distraction in between for the maxilla, and then in a second stage mandibular, a basic standard segmental procedure, an asymmetry correction by an asymmetric movement after BSSO, a typical bimaxillary osteotomy, maxillary advancement mandibular pushback, and another one with a little bit of genioplasty too. And the one thing that was common in all of these was the surgical splint. As has already been discussed, we do not need to spend time on these slides. There are things that we do before proceeding into the orthognathic surgery with proper planning and necessary arrangements. Like these ones, as we all know and do regularly. And we move on finally to get osteotomy wafers or splints, which are located, which are there to locate the dental arches in any pre-planned relationship and eliminate unreliable intraoperative guesswork. There are intermediate and final splints. And apart from this, we also heard about splintless surgeries, like I heard somebody say, I plan my osteotomies when I am walking towards the operating theater, or some who would grind of cusps to get to the desired occlusion. These were the surgeries which we knew to be surgeries splintless. However, the dictum is to reposition the mobilized maxilla relative to the intact mandible or vice versa, and also to incorporate some planned and educated adjustment made possible in the comfort of leisure and safety of the bench. We use splints. So they are both intermediate and final positions. Same thing applies for both. Now there is a proprioceptive guidance issue, as we have seen in our orthognathic patients. If they are not very meticulously being continuously handled by our orthognathic colleague at the time, we see they do not know where to bite. So the proprioceptive guidance is provided by a good splint. Wafer is also invaluable when we have just relied on a 3-point landing. These things are gradually going into days of the past, but yes, we sometimes had to, without a very good and very supportive orthodontic basis, preoperative finish before surgery, we had to depend on something called 3-point landing, or rather, every point of the occlusion was not stable. In this kind of situation, splint is the only way out. It stabilizes the segments in a planned position in segmental osteotomy, because otherwise it is like shooting a flying bird. It just floats around at the time of your plating. So the splint can provide with a second guidance where to hold things together. And there are ways. There's a recent literature, only it is a repetition actually, a 2022 literature, where we see that gradual settling of posterior open bites that are sometimes caused in class 2 situations with deep bite, that can be done by gradual trimming down of the original splint that we used for the surgery. obviously with other orthodontic inputs alongside. We'll move on from that. Now, in a big bibliometric study, it was noticed that the advances allowed surgical planning to become faster, cheaper, and more accurate. What are these advances? As has been already mentioned by our dear moderator, these we are talking about the custom splints which are made by the computer in the 3D printing technology. And it claims to be cheaper, safer, faster, etc. And to explain that, what has been produced has got 3 times mentioned here. Just a second, yes. However, without a standard splint that we normally use, in this computer guidance, one thing in multiple studies have come up, the actual physical impact of opposing teeth, point to point, as we feel when we are holding the 2 casts in the desired position. That is one thing that is missing in these technological splints, which are crafted beforehand without our usual use of articulator, plaster, and acrylic. They say that everything like the CT images, 3D model reconstruction, skull model creation, digitization of the markings, and virtual osteotomies are completed by a centralized service. I work in India in a standard setup, and it is seriously something you can only do if you have got the softwares and the printers and everything at your hand. We are trying to do these things from time to time over Zoom meetings and all, but it is so very much difficult to make people who are not surgeons actually operating to understand what exactly is that we want. They will match the millimeters anyway. Now we need things like a ProPlan software by Materialize. These are custom softwares, another 3-matic, and finally a special type of printer. And that's a huge cost involved. And the mean absolute distance error was 0.4 millimeters amongst those, the roll-up acrylic on the 2 plaster models, which we used to push down together to make the splint. Now through 3 big expensive softwares, we got an improvement in error by 0.4 millimeters, my friends. So 0.4 millimeter, I don't know how many of you are extremely worried about being precise too. Now comes the word, the splintless orthognathic surgery, personalized orthognathic surgical guide system. This is a preliminary study as early as 2017. So we are about 5 years into it, and the context and mentions without the use of surgical splints 3 times in one paragraph. I don't know whether that was due to hypersensitivity to acrylic or plaster, but see what it is. It is actually a 3D model in the computer where we decide and fabricate a cutting guide, cutting jig, through which we make the cuts. You can see the jig there and the cuts placed after the jig has been removed. And then we have similarly prepared in the new position some wide, specially prepared, specially fabricated custom plates, obviously at a significant cost of into technology. Same thing with the mandible, cutting jigs, and finally the positioning plates. Now this is the debate, splint or splintless. We have achieved a result, same result we all know can be achieved, leave alone that 0.4 millimeters, by 2 vastly different technologies, and fair enough that is. In these discussions, there has never been anything that is orthognathic surgery without a splint. These are the different type of splints that we have seen throughout in the presentation. Apart from obviously the mad monkey kung fu of iPlanet on my way to the operating theater or grinding of cusps, I have never seen anything throughout which is a splintless orthognathic surgery. What we have done is either in the first one, slide A, a hand-made external splint, slide B, a machine-made external splint, expensive one, or a machine-made internal set of splints. It is an internal set of splints is what we are fabricating in this patient-specific implant system. So, my dear friends, I call that splintless orthognathic surgery is a misnomer because it kind of makes you feel that there is no splint, there is no guidance necessary, there is something else that will give us the desired results. However, as we move on into civilization, into any development of science, we welcome very much this new technology. It is helpful, it is smart, it is a kind of like more sophisticated and cleaner, and we look forward to more surgeries with internal splints. Thank you.
Now I'd like to invite Dr. Arun onto the stage if he has any counter, Dr. Srijan. Thank you.
Good morning, everybody. Good morning, Chairman, sir. It's a proud privilege to present with the dignitaries and participating in this conference, where we have read their books and we have grown up. The topic is splintless, and what I'm trying to bring or highlight is the regular conventional way of making the splints, and where we might go wrong. And it's not that you have a splint in hand and you achieved everything. So the result depends on many things than the splint itself. So I'm trying to bring the facts related to the errors that are possibly can happen when you're constructing a splint. And these the collective errors from the beginning of clinical examination till the execution of surgeries will bring up very huge changes in the outcome. So when we talk about conventional method, we are talking in the area between 5 to 8 millimeters of change in the skeleton, whether it is maxilla, mandible, or bimax. And these millimeters do matter a lot. So here we go. So it's a mix-up. I have possibly missed a prosthodontist here. It's hugely a surgeon, orthodontist, prosthodontist, and a lab technician that are involved, who work together carefully with an understanding of mechanical and biological principles of jaw repositioning. And this is the sequence that goes through when you're trying to plan for an orthognathic surgery. So it starts from your clinical examination, and most of the time when you look at the patient, it's the three-dimensional patient you're looking on the dental chair, and but when you go through, but you'll shift to two-dimensional conventional X-rays, and then you start shifting towards the casts, and there how the errors keep collecting. So going by the list, clinical examination, radiographs, and I'll be showing you some of the literature which says the cephalometric errors. And then impression making, although we don't do it, it is done by the prosthodontist, and there is a lot of difference between the impression that you make from different materials and the registration of the occlusion. And then bite registration is another task, and the material used and the way you register the bite, the thickness of the material also adds on to the problems. And coming to the model preparation, as you all know, and it's a standard way of transferring a face bow with different articulators, and most of the time, majority, we use a semi-adjustable articulator. And when you transfer the bite and then try to duplicate the maxillary position to the cranial base and then transfer it to an articulator, there also again the collection of errors do happen. And then once you are constructed with the models, then cutting them, and then that's how things keep on adding and adding as you go towards the final stage of splint preparation. So I'm trying to just bring you those facts with literature support. This is how the head position that we look into, and starting from your clinical examination, positioning it into Frankfurt horizontal. If you just, it's not carefully checking the clinical check, you might end up with an anterior divergent chin or probably a posterior divergent, or a little bit of errors starts from here itself, the way you look at the patient. So the cephalometric limitations, which was presented by Lewis and Hostens in the publication, they said questionable accuracy of head position. And when you take a conventional X-rays, you need at least 3-dimensional imagination, and that is done by lateral ceph, an AP view, and a subintervertex view to have a fair idea of 3-dimensional skull. And over and under exposure of the radiographs might produce, identification of the landmarks, thereby drawing the linear measurements and angle measurements. So all these authors, Brand, Popsiel, and Sharifi, they always said this collective errors, that these inaccuracies in all these steps will definitely cause problem in planning accurately. So in one of the study by Pospisil, he did a prediction tracing, preoperatively and immediate postoperative tracings of 40 patients. And in this pre and postoperative inaccuracies were up to 60%. And inaccuracy in surgery after trying to assess the cephalometry was about 30%. And this was maximum with bimaxillary procedures mounting to 83%, and then single jaw surgeries with 30%. And that's a phenomenal error that you can encounter with this. And you know that face bow transfers is a very tedious job. I have missed out so many other things because I just wanted to fit it in one slide. So there are other steps that are involved after face bow, during registration of the occlusion, and then after registration transferring the occlusion onto the articulator. It's an exhaustive procedure, and multiple steps are involved, and a little changes in the angle will bring about a major changes in the linear measurements in terms of millimeters in the outcome of surgery. So by Zeiselman et al. In this evaluation of face bow transfers for the planning of orthognathic surgeries, said technical and methodological errors mounting up to a standard deviation of 2.7 degrees. So if you remember the V principle, the more distance you go from the angle area, the errors will keep on increasing. And then the mean deviation that he mentioned was about 7.7%. That is a bit alarming when you're doing a face bow transfer. And this, again, I have skipped a lot of steps when you transfer from face bow to the model and to the articulator. I have missed out a lot of steps. But here, when you are marking the horizontal and vertical lines, and the articulator itself, the device itself might have errors that we don't know. And then we start shifting on all our measurements, calculations that are, the collective errors into the model. And then we perform surgeries, and then there is a lot of wear and tear that are related to the material itself, which we consider as occlusion, which is ideally not. So this is the site, the link where we found, if you go through, that's a big list of the big pictures of each and every step that are mentioned in doing a model surgery. So a conventional method of model surgery based on 2T lateral cephalometric analysis will produce the errors from impression making and time-consuming steps in model surgeries, and the inconvenience of storing the dental cast, and if they are accidentally broken, if you fix and then again continue with your model surgeries, then there is a major risk of having an outcome that you are expecting. So how in Sharifi, in his article, how accurate the model planning of orthognathic surgery, he just tried to evaluate the accuracy of model surgery, 1, and 2, to identify the possible errors associated with the prediction process. So he divided the study into 2 groups. In group A, 22 with Lefort 1 procedure, and in group B, the 24 patients with Lefort 1 and BSSRO. So the preoperative and immediate postoperative lateral cephalograms were analyzed to calculate the surgical changes, and these were compared with those obtained from model surgery predictions. And the results were not really encouraging. The maxilla was under-advanced and over-impacted anteriorly than predicted by the model surgery. And the amount of mandibular setback was more than that predicted by the model surgery. This is the result. And in his conclusion, he said the face bow recording, the intermediate wafers, and most importantly, the auto-rotation of the mandible in the supine or position in the anesthetized patient would appear to be the principal reasons in the error, which we don't literally consider whenever we are doing on-table planning with the patient. So therefore, the mean value, whenever a study is done, the mean value always neutralizes the error. But what we should look into is the deviations from minimal to maximum deviation, that larger range, that's what we are supposed to look into. Because either one of the patient would have gone through either a major overcorrection or an undercorrection with this. So Bammer et al. Reported a mean vertical error of 0, which looks really lucrative, but a range of errors ranged from 2.3 to 2.4 millimeters. And Von Sickles reported a significant mean horizontal error of 3.6 millimeter. This is very considerable whenever we are talking for orthognathic surgeries, when it is ranging between 5 to 8 millimeters of changes that we are looking for. 3.6 millimeter is really disastrous. And there are again many authors who are really not happy with this kind of the results of outcome and versus plan. If you look at this, it's all opinion says significant inaccuracies, disappointing type, and it's in POPSICL, the POSPICL, 60% outcome showed significant inaccuracies defined as errors greater than 20%. That amounts for 2 millimeters roughly. Same thing was supported by Polido and Sin. And McCain said outcome versus predicted, the outcomes of predicted outcomes as disappointing with errors up to ranging up to 6 millimeters sometime. And then an equivalent of 20 to 30% reported by Jacobson et al. And in the Sharifi is said 50% of surgical outcomes showed inaccuracies defined as values greater than 1 standard deviation from the mean, 1 millimeter standard deviation from the mean. So here are some of the cases just to illustrate. These were done with splints, of course, but the changes were a little different from what we expected. So this was a case with the mandibular advancement and with the splint, and immediate post-op we had a relapse of 3 millimeters. And this is where, when we talk about what we prepare on a lab, is different from what we do on a patient who is lying down in supine with anesthetized with all the soft tissues relaxed. So these are the kind of results you get. A maxillary setback and a superior repositioning. We didn't achieve anything much in this case. There is an incompetent lip and not very pleasing profile though. And fortunately, the patient was forgiving, because in the gross problems with the patient's appearance, any little change they tend to accept unless you have done a bad counseling preoperatively. So the patient was really forgiving, because even though if she was not a wholehearted smile, in a partial smile also we are able to see the gums, and if you imagine if she smiles wholeheartedly, it was not a really pleasing gumminess as such. And this was a splint which we tried to get her a little better profile with convex profile, possibly because a female with a convex profile should suit. And we planned for a bit of overjet when we planned the splints, but post-operatively it ended up with an end-on relationship, bringing about a little anterior divergent of the chin, which we didn't expect. The patient was happy though. There's another case which was referred to us, which was performed with every other detailing by an orthodontic colleague. And what went wrong, surgical or orthodontics? We don't want to debate on that. But splints were used with intermediate and final splints. This was the preoperative case. And this is how she ended up with the first surgery with the surgeon. And then the patient was not really happy. Of course, it ended up with like a bimaxillary protrusion kind of situation with severe, convexity in the midface. And we had to take her up for a second surgery. And then this is what we could achieve. And this is again, I actually did not use a splint at this stage. We just wanted to, camouflage the already damage that was already done. And this is what we could get. And these are the pre-op and the first surgery and then corrective surgery cephalograms. And finally, this is what she got. Ultimately, we want to reach a goal of getting the patient into this kind of a confident-looking phase. But the hurdles that we face during this to reach this goal are many. So my take is just as much as possible, try to minimize the steps in in the lab or outside the patient, so that you can reduce the errors.
Good morning, everyone. So very rightly pointed out by Dr. Arun that there are certainly many steps, many mechanical steps during the fabrication, in the process of fabrication of the splint, and at any stage things can go wrong. One small mistake in the beginning can get amplified and certainly lead to disaster. So disaster happens, when well-established procedures are not followed. So same is true for splints also. Splint is, like a product which has many steps during its fabrication, and each step has to be followed meticulously. Only then you will have a good product, right? So we can, there is absolutely no doubt that there is a possibility of introducing errors, but if we follow each step very diligently, then probably we can have a splint which is well within, which has errors well within the clinically acceptable limits. So we can minimize the errors of making an impression and pouring a cast by taking an impression with rubber-based materials, using a larger tray for alginate. So this will reduce the distortion of the impression by using tray adhesives and by blocking the undercuts before we take that impression. And while removing that impression, instead of pulling onto the tray, we push on the alginate, so that distortion is minimal and there is lesser possibility of the separation between the tray and that alginate or whichever impression material we are using. So these are like standard prosthodontic procedures. So if we stick on to the standard procedures, then certainly it is possible to have a result which is clinically acceptable. Once we are pouring the cast, we have to take care that we use a vibrator to eliminate bubbles. Any small bubble at the cusp tip is certainly going to allow acrylic to flow into that, and that is going to cause interference, and it will not allow that splint to fit onto that teeth. Now, a wrong articulator selection itself can introduce an error to the tune of 2 to 3 millimeters. So we have to choose the articulator carefully. For all maxillary osteotomies with height changes and for all Bimax procedures, we should use the semi-adjustable articulator. Now, one of the major sources of error, as pointed out by Dr. Arun, is the phasebow transfer. So this allows us to orient the maxilla to the cranium and orient the maxilla to the intercondylar axis. A very important step, since we are doing everything outside the patient and onto the articulator. And if we don't have a correct transfer of this relationship to the articulator, then whatever we are doing is certainly going to go wrong. But then, so many techniques have been described, and now more or less it is well established that if standard procedures are followed, then certainly we can have an acceptable level of accuracy in the phasebow transfer. So special attention is paid to where we are keeping the orbital pointer, because that decides how much of the angular discrepancy we are incorporating there. And then another point where discrepancies can come in is where the stem is fixed to the clamp. Now, if the clamp is not completely loose, it is entirely possible that when you remove, it is simply going to go away from where you had fixed it. So at the time when the stem is inserted in the clamp, it must be absolutely loose and passive. The relationship has to be passive between the three elements. Only then we go ahead and tighten the clamps in the sequence of 1, 2, and 3. So they are marked, like all the three locks are marked, and we have to go like from 1, 2 to 3. Now once we have done that, while removal of this phasebow also, we have to be very careful that we don't apply too much of force on that, otherwise that's going to change the relationship, and we don't keep the phasebow onto the table, because all that force is probably going to be taken by the fork, and probably there is always a possibility of changing the relationship a little bit. So we have to transfer it directly to the articulator. And we should have prepared our articulator before we have gone to the phasebow transfer. So the preparation of the articulator basically involves setting the articulator using the recommended values for general all patients. So what is recommended is that condylar guidance is set to 30 degrees, the lateral inclination is set to 15 degrees, and the centric lock is tightened. In addition to that, the incisal guide is set to 0 degrees and the lateral wings are set flat. Now, this is a generalized recommendation. If you have, especially like asymmetry patients, there we don't have, if we don't follow special procedures, then what is going to happen is the relationship of the maxilla to the intercondylar axis. So, it's not in relation to the midline, it's not 90 degrees, this intercondylar axis. So, but in the articulator, when we are shifting it, automatically, it's like the exact relationship to the facial midline of the intercondylar axis is not going to get transferred onto the articulator. So in those cases of asymmetry, we have to use, we can use a facial midline jig to bring in accuracy, and same is the case for the condylar guidance. All the patients will not have the same condylar guidance. So if we have any suspicion that it is too steep or too shallow, then we can certainly take a protrusive bite, again a well-established procedure in prosthodontics. So we can use a protrusive bite to bring in more accuracy and accurately adjust the condylar guidance. So we use all these procedures to reduce the errors to within the clinically acceptable limits. Now, before we keep the maxillary cast onto the fork, we have to ensure that the fork itself is well supported. Otherwise, even just by keeping the cast onto the fork, we can introduce an error up to 2 degrees, 2 to 5 degrees actually. So before we actually keep the maxillary cast, we have to stabilize the fork with the fork support. And another important thing to remember there is when we are fixing that, when we are tightening that fork support, it must be touching that fork passively. If we force it up, again we have introduced an error of 2 to 5 degrees, and if we have kept it low, then when we are keeping the cast, there is again a possibility of introducing an angular change there. So once we have supported it, then we keep the cast and we visually inspect it from all the directions that the cast is well seated there. Now, probably one of the number one reason of errors in splint fabrication is an inaccurate transfer of the centric relation. So we certainly don't want to record a centric occlusion and think that we have recorded a centric relation. Now the problem is, all the orthognathic patients, they have already undergone orthodontic treatment and they don't have good occlusion when they have come here at this stage of recording their centric relation. Now, the problem is that these patients, because they don't have good occlusion, their proprioceptive reflexes are altered. And it is very difficult compared to a normal patient to bring them, to teach them to bring the jaws in a position where we want to help in taking the centric relation. So it's very important that we spend adequate time with these patients in training. So training these patients is single, most important step which can reduce the errors of taking, recording a centric relation. Now, once we are very sure that we have adequately trained that patient, then we go ahead and take this centric relation, and we ensure, we train the patient and we ensure that the patient does not bring the teeth into complete occlusion. The moment he has done that, we have not recorded the centric relation, we have recorded the centric occlusion. And one of the indicators of that error, that instead of relation we have actually recorded a centric occlusion, is perforation of the bite. So we look at the bite against the light and we see ideally it should be translucent, with no perforation. Perforation, if you see, then you should go ahead and discard that and repeat the process till you are very confident that yes, indeed you have recorded only the centric relation. Now we draw lines on the cast, so we scribe those lines. Now obviously we are doing measurement, once we scribe the lines, we cut the cast and we are doing point to point measurements. Now if the line itself is thick, let's say we have used a pen which bloats, then obviously if the line itself is 0.5 millimeters, then there is certainly a possibility that when we are measuring it from any point there, we can have 0.25 to 5.5 millimeters of error just in the measurement itself. So obviously we need to use a thin pencil or a thin marker, right, and not anything that can bloat on this cast. Another thing we have to be very careful is matching the yaw lines. That's why I have kept this back photograph to show that yaw lines. Now, if we don't match the yaw lines, what is going to happen is, if you don't intend to cause any rotation, then if the yaw lines are not matching, obviously the splint is going to look good. It is certainly going to fit maxilla and it is certainly going to fit mandible also, but inadvertently we would have introduced a rotation. So maxilla is going to get fixed in a rotated position, and because of the splint, the mandible is also going to get fixed in a rotated position, and all goes well, but till you put the fixation onto the mandible. Once you fix the mandible, you will see one side angle going in, the other side angle getting kicked out. So yaw lines, special attention. So what we are doing is, these are all well-established procedures, right? We are not really reinventing the wheel here. We are just reiterating that all these are well-established procedures which need to be followed diligently to have an accurate result, that's all. So nowadays glue gun is used commonly to stabilize, and one important requirement of that is the cast has to be dry. So, we should use an overnight dried cast before you use this glue gun. So this is, I think most of the people are now using this one. Now, when we are fabricating two splints in bi-jaw surgery, intermediate and final splint, now what happens is, after we generate the first splint, there is certainly a possibility that the cusp tips might have worn off. And if we use the same, ACLIC will just record that, and when we are trying to fit in that splint on the teeth, it is not going to seat. So whatever amount of trimming you do, it is very unlikely for you to make that splint seat onto the teeth. So we have to use a second set of mandibular cast to fabricate the final splint. Now the splint itself, the indentation should be shallow. Now, many a times, we have that in mind that it should seat in nicely over to the teeth. But what happens is, if we have deep indentations in the clinical setting, that may not seat completely. It may interfere with the brackets also. And what we want is just a three-dimensional positioning, that's all. We don't exactly want, because the rest of the things, it will be held by the hardware and it will be in intermaxillary fixation. So what we need is three-dimensional positioning for the splint, and just shallow indentations are adequate for these splints. And the extension of the splint, we should not extend it beyond the half of the second molar. If you are planning to use wires for stabilization, then we have to keep a provision laterally around 1 to 2 millimeter. We have to extend the splint laterally to allow for those holes. Now, the holes themselves, we don't drill vertical holes. Instead we try to align these holes from embrasure to embrasure. So that also helps us passing the wires. It becomes a lot easier for the wires to go under that arch bar. So small things that increase the accuracy and increase the ease. So even though we may be thinking that we have followed all the steps properly, but it is extremely important that before we go in the OT, we verify that splint in the patient. So what exactly are we verifying? We are only verifying whether it seats onto the teeth without any rocking. So however it is seating onto the cast, exactly the same way it must seat individually onto the maxilla and mandible. It is just for the sake of the photograph, it is fitting both. Of course, in most of the cases it is simply not possible, because this is final splint, and certainly it can't be replicated in the patient. So this is just for photographer. But the important thing is we check its seating individually on each jaw. If there is a slightest of rocking, then we must revise that splint. That's